With that, I'd like to introduce Dr. Carroll Overton. Dr. McDreamy, by the way. Several years ago, the what was it, News and Observer? News and Observer, yes. He was the official winner. Congratulations on that. He'll be speaking to you.
Thank you. Well, good afternoon. Is this working okay? So what I'm going to talk today about is vertebral compression fractures and how we work on them to try to relieve pain with insufficiency fractures of the spine. As Dr. Van Arthros was saying, fragility fractures of the spine are extraordinarily common. And in the interest of time, I'm just going to zip ahead. What we talk about in the spine is this downward spiral, osteoporosis, weakening of the spine. Patients get an insufficiency fracture in their spine and they really deteriorate. And the way I originally got into this actually was with my own family. I had a grandmother who was 87 years old, walking 1 to 2 miles a day, perfectly fine, gets a compression fracture. That was it. She was totally debilitated thereafter. She never recovered. And it was an example of this downward spiral. She could no longer move the way she used to. She couldn't breathe the way she used to, and she couldn't walk the way she used to. And if you take an elderly person and make them stuck in bed or in a chair, they deteriorate very rapidly. As we talked before with osteoporosis, weakening of the bone, you get larger spaces in the bone. And let me go to this one real quick. So why would you have to worry about osteoporosis-induced fractures in your spine? Well, most importantly, in America, there are 700,000 a year of vertebral compression fractures related to osteoporosis. So if you think about it, that's 2,000 Americans a day are having one of these fractures. That's a huge number of patients. And like my grandmother years ago, we used to have nothing to offer them. So that was an enormous percentage of the population that's terribly debilitated every year. Well, now we have something to offer to try to help with that. I'm just going to skip through that. We saw this before with Dr. Van Arthros, how common osteoporosis is. Just in the interest of time, I'm going to scoot ahead. The human cost, just like we were talking about, loss of height, increasing their kyphosis, difficulty with balance. As a patient becomes more kyphotic, they decrease the size of their abdominal thoracic cavities as they become increasingly hunched over, decreases their lung volume, early satiety. All these things can severely affect the patient's ability to maintain a normal lifestyle. And this is a perfect example. This patient in her 50s, normal posture, multiple compression fractures. And here you can see how her abdomen is now protruding. Her thoracic cage is now more compressed, so her lung volumes are decreased ability to exercise, and it really just is terribly debilitating. In addition to just osteoporosis in and of itself, patients on long-term steroid use get osteoporosis. So we've had patients as young as 55 with long-term steroids who have had compression fractures. So it's not just the elderly, it can be anybody, just like Dr. Van Arthros was saying, anyone on long-term steroids can also have a compression fracture. Next is bone metastasis. We do see patients who have metastatic disease to the spine. That can weaken the spine just like osteoporosis and can cause a compression fracture. So it's not just osteoporosis, but malignancy that we work on as well to try to alleviate pain in spinal fractures. With respect to history, if you break your hip or your wrist, you either get a cast on it or you get some hardware put in it. But up until 15 years ago, if you broke your back, they just said, well, nothing you can do for it. Try to put these elderly people on pain meds or just stay in bed. But we had nothing to offer. So thankfully, once vertebroplasty came into being, we actually had something we could do to help. Because once again, if we don't help these elderly people get out of bed and get their mobility back, mortality rate is very high and debilitation is significant. Again, orthopedic principles of fracture management, you break a bone anywhere else, it's going to get fixed. So that's what we're trying to do now with the spine as well. So let's say you have a patient come into your office who, let's say in their 60s or 70s, you know they have osteoporosis, they have a minor fall and they have terrible back pain, and you're worried that a vertebral fracture could be the source of their pain. What do? Well, typically what we do is start with a regular x-ray. If it's in their upper back, say between their shoulder blades, you just get a set of thoracic spine x-rays. That's the quickest, easiest thing to do. And the next thing thereafter, if you do find a fracture, what we typically get in all these patients is an MRI. That will delineate the age of the fracture and whether or not we can actually fix it with vertebroplasty or kyphoplasty. And oftentimes on a plain film, you'll see an obvious fracture But on an MRI, you'll see the fracture you know is new, but there'll be one next to it that you couldn't see on the regular x-ray. So you realize you might have two to fix instead of just one. And it also tells us if the fracture is safe to fix. Make sure that there are no bone fragments pushed back towards the cord or anything like that. So the key thing is back pain patient, you're worried about a fracture, get regular x-rays first. If it looks like there is a fracture, the next step is MRI.
What if it's negative and you're suspicious?
If the plain film's negative, then go right to MRI after that. The plain film is a good screening tool, really just get a lay of the land, so to speak, of what's going on in their spine. Sometimes we'll even see that it's not osteoporosis, that it's a metastatic lesion. So you sort of go into the MRI with some knowledge ahead of time of what you're looking for.
With the MRIs, you always have to order x-ray anyway. But it sounds like you're saying whether it's positive or negative, either way you're going to get an MRI.
Well, yeah, it's potential. Let's say the thoracic spine films or lumbar spine films are totally normal. In that case, it may be a disc issue or it could be a pulled muscle issue. It could be something that may or may not in your sort of decision tree decide if you need an MRI or not. If it's just flat out normal and your patient doesn't have osteoporosis, then you sort of go to that other decision tree. Well, back pain, what else could it be? Degenerative disc disease or pulled muscle, some degenerative facet disease, and those are plus or minus depending upon whether or not you think you need an MRI. Here again, don't stop with plain films, go to MRI. Here's an example of a compression fracture on MRI right here. It's compressed and it looks white compared to the other vertebral bodies. That's edema. That's what is the sign we look for the sign of a new fracture. Because it's the new fractures that we can get pain-free. The old fractures that have been around for years, we really can't do much for. Here again, here's a fracture right there. Just more examples of MRIs. You can see how white that body is right there. That's edema, fracture. Bone scan is what we used to use. We still use a bone scan in case you have a patient with an aneurysm clip that they're not allowed to get an MRI, or if they have a pacemaker and they're not allowed to get an MRI. If that's the case, we go back to the old standby of a bone scan and potentially a CT scan. But otherwise, those are typically not necessary. So once again, the summary: onset of pain, kyphosis, MRI, plain film, MRI, bone scan, CT if you can't get an MRI. Just different types of compression fractures. Some of them wedge forward, some of them are biconcave, some of them are just flat out crunch top to bottom. Progression, this is an example of how a patient progressed from January to May from a mild little fracture at the bottom to pretty bad to just totally flat and the cord's compressed. Another just example of progression. Here it was okay, maybe a little bit of a crack on top and it's progressed, and here's the edema here of an acute fracture on the MRI. Just again, that one progression. Just jump ahead. Okay, vertebroplasty and kyphoplasty. Again, two different techniques, and there's differing reasons to use one versus the other. Some people just prefer one over the other. Some of us choose vertebroplasty if it's in upper thoracic spine where the bones are smaller. It's easier just to get a needle in. As you get down towards the lumbar spine, it's easier to get that big kyphoplasty needle in and use a balloon to try to get some height restoration. Basically, the outcomes are identical for both. So it just depends upon the site of the fracture, how badly compressed it is, and the doc who happens to see the patient. But the outcomes are the same. This shows how we do it. Just a quick example of a needle going in under fluoroscopy. This is vertebroplasty on this side. The needle's going in, filling up all those interstices with cement to set that fracture in place. And here's kyphoplasty, where we go in with a balloon first and try to get a little height restoration. Makes a cavity, and we fill that cavity up with cement. Contraindications. Are there reasons that you should not get this? Well, if it's not a fracture but some other source of pain, we wouldn't work on that. If there's infection, we can't work on them. If there's significant bone retropulsion towards the spinal canal, or the patient has leg weakness or other signs of nerve compression, we can't work on those. And others who have compression fractures, every now and then you find one incidentally and their pain's really not that bad and they're doing perfectly fine with a little bit of pain medicine. You know, we're pretty conservative. If they're getting around doing fine with just minimal pain, we say just watch them a little bit, see how they do. Cancer patients, again, often we'll do a biopsy first to prove whether it is or is not a metastatic focus to the spine. Doing a vertebroplasty or a kyphoplasty will not interfere with radiation. Our oncologists, we very typically will do these, and they may or may not need radiation after we fix the fracture. Potential complications are minor ones, are 1 to 10% or less, permanent less than 1%. So there really are very rare complications for this procedure. Rarely you might have some cement leakage or a fracture of one of the pedicles going towards the bone. Again, less than 1% chance of anything going wrong during the performance of the procedure. Again, the main thing to avoid complications, appropriate patient selection. And we see all these folks in the office first. If you have a patient come in your office and you're worried about a compression fracture, we'll see them in our outpatient office, evaluate them, talk to them, and we can actually get the MRI taken care of. If you've just had a plain film done as an obvious fracture, we'll see them, talk to them, evaluate them, see, and get all that taken care of. And doing that, we try to take the stress off of you and trying to figure out what you need to do, whether or not it needs to be a bone scan, an MRI, and how many levels to treat and whatnot. Here, let's just jump ahead. Just showing how we're doing the procedure. I'm just going to skip through this because we're getting close to 2 o'clock. Again, fluoroscopy, just like the epidural steroid injections, we use x-ray to do the procedure. We do these typically in the hospital with a very state-of-the-art x-ray machine to show us right where to get the needle placement and cement injection. Bump ahead. This is an example of vertebroplasty. We've filled up these broken bones with, it's officially called methyl methacrylate. It's cement, or some even call it glue. Here's an example of a fracture right here. Needle coming in. Pretty big needle, as you can see. I never show these patients the needle ahead of time. I always joke. I say, if I show you the needle, you might not let me do it. Needle's going in, and then that blob of cement. It's not the prettiest procedure in the world. It looks like this amorphous blob of just stuff there, but amazingly enough, patients get better, and half of the patients get better that day. The other half, we tell them it's like the old adage, you break your wrist, get a cast on it, it needs a few weeks to heal. So the other half who don't get better that day, we say just give it a few weeks, now it can start healing, and over 90 to 95% of patients will get their pain resolved with this. Lastly, sacroplasty, relatively new procedure, very similar to vertebroplasty, but what we're talking about is the sacrum. Sacral insufficiency fractures, again, typically female osteoporosis. They may or may not have trauma, have fallen. They typically have lower pain down towards the hip and buttock. Now, up until a couple years ago, there was truly nothing to do for these, and often they're worse off than our spine fracture patients in that our spine fracture patients often get relief by at least lying down and getting the weight off of their back. The sacral insufficiency fracture patients we see typically can't get any relief anywhere. They can't sit, they can't lie down. So this is even more rewarding often than the vertebral type fracture treatments we work on. Again, it's very similar to vertebroplasty, kyphoplasty, and MRI will give us the answer we need as to whether or not it's really a fracture down there and if we can fix it. Outcomes are the same. We get over 90% of patients relieved of their pain. And just an x-ray image of how we do it. Sacrum's down here, this needle's going in. Typically, unlike the spine fractures where you can actually see the bone compress, with the sacral fractures, you typically can't see it on x-ray. And there's a spine very similar to what we saw before with the epidural injection down below, but we're a little bit more forward and actually in the bone for this procedure. And again, leaving cement behind as we bring that needle back, just filling in the fracture lines along the sacrum. Again, this just kind of amorphous blob, Gumby-like looking appearance of cement there. But it takes their pain away, and it really sets that bone in place so that it can stop moving and shifting and crunching, and that takes their pain away. And even though theoretically it's 50-50, half the patients get better that day and the other half over the next few weeks, our sacral patients actually we're seeing about 75 to 80% of them get better within 2 hours of getting the cement in there. So, right at 2 o'clock, that was kind of a whirlwind. Have any questions about sort of how we take care of the patients or how we can help you get patients in the loop for these procedures to help them with their pain?
How long have these procedures been around?
Vertebroplasty, kyphoplasty came in the country probably around 15 years ago from Europe. So we've been doing it for quite a while now. It's just routine. In fact, rarely does a day go by now in our practice that we're not doing one somewhere in the practice of all the hospitals we cover. Mm-hmm.
For cervical discs?
Well, for cervical fractures, well, there's one guy I know of in Atlanta who does them. Most of us won't work on those, and typically in the cervical spine, if you have a fracture, the thing you got to think about is malignancy. So most of those go to radiation. There's one guy that I know in Atlanta where the only way to get to the cervical spine is right through the mouth, so most of us won't do it. So You can, but again, if anything above about T6, you got to really think there's cancer as a source. It's very rare to have osteoporosis-induced fractures above T6 all the way up into the C-spine. But most of those get treated conservatively.
One thing you said, MRI, STIR.
STIR, that's the specific sequence for looking for edema, and that's routine in our practice. Unfortunately, citywide, some of my patients have come to me getting MRs elsewhere, and unfortunately they didn't have those sequences in their standard protocols. In Raleigh, pretty much everywhere that's standard.
That really helps pick it up.
Shows that edema.
If it wasn't a STIR. You know, long term, how far out can people have cement stay in place?
Stays put.
Deteriorate?
No, that cement will stay put. In fact, I carry these little samples of cement in my pocket. My kids have beaten on them and thrown them on the floor and whenever they get hold of my white coat. I always show that to the patients. I've had the same chips for 10 years and they've been beat on probably 1,000 times. They still haven't cracked. So that stays put. The biggest thing is having another fracture. We know osteoporosis is system-wide, so if you have one fracture, I tell everybody, just do whatever you can to not fall because we know your bones are weak. Your biggest risk is having another fracture somewhere else.
What about prophylactically? They thought about going up.
Right, that's controversial. In Europe, I think some people have tried that, but even though the risks are very low, you hate to impose any risk on a patient not knowing if it's really necessary.
Is there any increased risk of having another fracture elsewhere after you?
There is. The rates are a little bit controversial. The biggest issue there is if you're putting the cement in the vertebral body and it leaks out of the bone, because in your mind's eye, if you can imagine that cement poking up into a disc, it's like a spike. And if you have a bone above it is weak and you have this hard cement spike pointed at it, there's a greater risk that the bone above it will then crunch. But as long as you don't have any leakage of cement, you're just at the same risk you were before with respect to osteoporosis and your overall risk of fractures if you have osteoporosis. But I tell everybody when we're done and we see them in the office 1 to 2 weeks later, hopefully their pain's gone as it is most of the time. If you get new pain, just come back. We'll shoot an x-ray because you're always going to be at increased risk if you have osteoporosis for another fracture somewhere else. There's no real good number to stick on it, but if you have osteoporosis, it's always in the back of your mind for the risk.
But this cement, does it actually restore height to the fracture not? Why does that? Intuitively, I don't know why it decreases the pain.
Right. Well, what we believe it does is it does a number of things. One is you have this bone that's cracked and crunched. It can literally move. In fact, there have been cases where I have them on the x-ray machine. As I'm watching my needle go in, I can see that bone shifting with every breath and moving because it's broken. You imagine breaking your arm and I started wiggling. It would hurt like, you know what. The same thing in the spine. Well, that cement goes in and it just sets it in place. And it stops all that shifting and moving and crunching. And we think that's the main source of pain relief. So it's really like putting a cast on an arm, but we're putting a cast inside the bone.
Carroll, he was also asking about the restoration of height.
Oh yeah, that's right.
Do that.
Height restoration is extremely controversial. That was where the kyphoplasty technique came in the beginning. They were really hyping up height restoration, and you really don't see that much height restoration. That's where you put the balloon in first and try to get the bone up. Again, the outcomes are identical between the two procedures, and it's more, one, personal preference of the doc who's doing it, and two, just how flat the bone is as to whether or not you'll do one versus the other.
So this unevenness of the bone getting crunched, does that put torque and stress on the vertebral column above or below and make it more likely to have problems?
Some companies talk about that, but it really hasn't panned out to be true. In fact, overwhelming majority of patients I've seen over the years that we treat one fracture is rare, not rare, it's uncommon for us to see them again. I can think of 3 or 4 patients where we've had them back a year or 2 later to do another fracture, but of the hundreds and hundreds of people we've seen, it's pretty uncommon actually to see them come back. I think most of that is because patients are now, or their medical docs are pretty vigilant about getting them on their osteoporosis meds and they're getting better bone strength. You know, that one fracture is kind of a harbinger of things to come, so they get to their doctor, they get on the pituitary stimulating meds and whatnot to get their bones strengthened. Any other questions?
I do.
Sure.
If you can comment for people, one, is there a height below which you won't do it? Mm-hmm. And 2, would you consider doing it in the cervical spine?
Yeah, height below which, when it gets pretty flat, like that one slide where it showed the progression, if it's really flat, we pretty much can't get a needle in there. If it's above 20%, we've got a chance at it. And again, cervical spine, very few people will do that. I don't know, Mike, if you've got any thoughts on that too, one for the other interventional guys. I know Dion in Atlanta, there's one interventionalist, I've seen him do it, but with the cervical spine, about the only access is going right through transoral, which is pretty risky, and I don't know of any other folks really doing it nationwide. Have you heard of anybody, Mike?
Really? He's talking about the needle is the 13 gauge. That it's kind of unsafe to get the needle in there sometimes.
Yeah. So again, cervical spine, if you have a fracture up there, it's typically a malignancy, and most of those are just going to get radiated, and that will take care of the source. Any other questions? All right, well, thanks very much.